Welcome, everyone. I'm Kman. I'm an emergency physician at Ohio State, and I'm also a disaster responder with Ohio Task Force 1, which is Ohio's FEMA Urban Search and Rescue Team. I've been interested in disaster preparedness and pandemic preparedness really over the course of most of my career. I've done different disaster deployments and am now helping with Ohio State and the state of Ohio's COVID-19 response. So let's talk a little bit about the virus, and then we can talk about personal protective equipment and disaster preparedness as it pertains to pandemics. So I'm going to go light on the pathophysiology. I think COVID-19 has been covered in such great detail, but the outbreak started in Yunnan, China, and it was initially linked to a large seafood and animal market. Coronaviruses have been around forever, and you probably have heard the word coronavirus, and usually these cause the common cold. But this particular virus is spreading now person to person via droplets, and it's very contagious. Symptoms go very mild to severe respiratory illness, ARDS, and death. The symptoms that we're seeing are fever, cough, shortness of breath, and body aches. And one of the things that I think is kind of interesting is we're not really seeing a lot of nausea, vomiting, or runny nose or rhinorrhea. So somebody has nausea and the sniffles, they probably don't have COVID-19. So the incubation period is 1 to 14 days. And the 14-day number is important because that's why people have to quarantine for that period of time. Most patients become ill within 10 days of exposure. 80% of more of patients are not requiring hospitalization. And I think that's why we're seeing people, younger folks in particular, not taking this disease as seriously as they should be. The estimated mortality is between 1 and 3%. And really, one of the things that I want to stress as much as anything is these numbers change pretty much by the day. The mortality rate in South Korea is lower. In Germany, they have a little bit lower mortality rate. I think these numbers, we won't know what these numbers are until the disease process comes and goes. But what we do know is patients that are at severe risk for COVID-19 are older adults, patients with chronic medical conditions, including heart disease, diabetes, lung disease, and people who are immunosuppressed. So I talked about the symptoms. Again, the thing that we worry about most is the respiratory symptoms leading to severe ARDS requiring a ventilator. On labs, we're seeing leukopenia and lymphopenia with sometimes pulmonary imaging showing ground glass opacities or patchy consolidations. I will say that CAT scan is not going to make the diagnosis of this, so we shouldn't be CAT scanning all these patients. Again, I'm going to talk about finite resources as we move through this little talk. But what we're doing when a patient comes to the emergency department or to the hospital, we're asking them about their symptoms and whether they have any contact or travel exposure. Of course, we are seeing community spread with this, but it's still worth asking someone if they recently traveled abroad or got off a cruise ship. When that happens, we're putting a regular routine surgical mask on the patient, and we're putting them into a private room with a door that closes. We initially were instituting airborne precautions, but now I think it's pretty well recognized that we're not going to be able to keep all of these patients in negative airflow rooms. So we get the patient masked. That prevents the droplets from getting out to the providers, the nurses, and the doctors. Get the patient in a room with a private door that closes. If we can institute airborne precautions, we will, but definitely contact and droplet isolation immediately. And then we go in and see the patient. When we go in to see the patient, what's essential is that we stick to strict donning and doffing of our PPE. So we've talked a lot about masks. So a procedure mask or a regular surgical mask, I don't have one here at my house, but that would be what we would put on the patient. And we're allowed to use that if we're around a patient and we're not doing any droplet generating procedures. So if we're intubating a patient, if we're doing nebs, if we're doing a test, which is a nasal swab that goes in the nose, then we need one of these. This is an N95, and I'll just show you, it kind of goes on this way. And you got to make sure that it's on correctly, but you can pinch it and it gives you a lot tighter seal. Now notice I shaved and I've been fit tested for this. So this one's okay if I have a face shield or goggles to do a procedure with a patient like that. These are the ones that healthcare providers really need. So absolutely, please save these for us. Another option is what's called a half face piece, and this is mine. There was a cache of these in Central Ohio, so a lot of the physicians and nurses that are working in the emergency department have these. Again, you do need to shave. You need to be fit tested for this, but this one goes on similarly. And obviously I'm not going to be able to talk on the phone, but goes on like that. And so I've been fit tested for this, and I can breathe. When I take it off, I'm going to be able to decon this and clean it off, and I'll be able to use it again. So a lot of providers have one of these. These have been put out to us as something that we can use. You get one. If you lose it, you're out of luck. So that's a half face piece. So those are some of the isolation things that we're talking about. As far as treating these patients, you want supportive care, oxygen, IV hydration. There's really no medications and there's not a vaccine yet. There's trials going on. There's a lot of discussion on the listserv about different types of antiviral medicines, just not happening. As far as drive-through testing, we do have drive-through testing in the city. I believe every health system in the Central Ohio area has it. Just know that we have to prioritize these tests. So one of the things that I'm helping with at my institution is, how many tests we have and the supplies that we have. So I can tell you that 2 days ago, we were running very low on the medium that the test goes in. So this is a swab that goes into a liquid, and we actually had enough swabs, but we didn't have enough liquid. So you're going to hear a lot about supply issues as we go through this pandemic. And we were able to procure some more, through like research labs or the university, but we definitely need to think about these supplies. So right now we're doing, between 200 and 500 drive-through tests typically per day. We're trying to prioritize people who have symptoms or contacts. And as this pandemic progresses, I will tell you that we will probably stop testing anyone with mild symptoms who isn't that sick. Just like we do during the regular flu season, we pretty much know what you have. So we're not going to waste tests there. We're going to test the immunocompromised, the elderly, and the very sick hospitalized patients. So I'm going to transition into how we plan for these pandemics. So I will tell you, in the disaster preparedness world, one of the first things we do every year is what's called a hazard vulnerability analysis. We look at the things that could happen to us and are dangerous. And on our most recent hazard vulnerability analysis, infectious disease was one of the highest risk events, along with flooding. At least at our medical center, we're within the 500 and 100-year floodplain of the Olentangy River, which is why we raised Cannon Drive. We look at these hazards and we try to mitigate and prepare for them when they happen. So we knew to be ready for a pandemic. In Central Ohio Trauma System does a great job of coordinating the supplies and the response to these things. So we have Ohio EMA, Franklin County EMA, Columbus Public Health, Franklin County Public Health, Nationwide Children's, Battelle. All these organizations are working together to help respond to these issues. People often ask me, how do we know what resources everyone has? Well, Central Ohio Trauma Systems keeps track of a bed board. So we have a certain number of negative airflow beds at Ohio State, and they have a certain amount at Riverside, a certain amount at Grant, a certain amount at St. Anne's, and they can monitor who has what and how full each hospital is, including their emergency departments. So I think in the region, we do a pretty good job of coordinating preparedness among hospitals. For example, during a regular influenza, we may run short on masks, and we may be able to get some from a different health system or from a different supply. So as we prepare for a pandemic, we really think about three things: space, supplies, and staff. So it's really important to know how much space you have. So like I said, the COTS group tries to figure out how many beds there are within the region, and each health system is trying to figure out how to use different beds and how much space they have. As far as supplies, you've heard a ton about masks. These N95s that healthcare providers really need, we're running low on these. So when you think about supplies, think about N95s, think about half face pieces, think about swabs, testing, mediums, gowns that we wear when we go to see patients. And then we think about staff. So if you're on quarantine, if you're sick with COVID-19, you can't work. So frankly, that's important. So one of the things that I wanted to talk about a little bit is I was involved in writing Ohio's pandemic scarce resources plan. So from 2014 to 2016, we wrote Ohio guidelines for the allocation of scarce medical resources. And really the goal of that document is to allocate resources when the focus shifts from an individual patient to patient-centered outcomes. So crisis standards of care or the allocation of scarce resources are things that you're going to see on the news. This is a change from the conventional standard of care that we have to hospitals using adapted spaces, like using the recovery room or the PACU or endoscopy as ICUs, staff and supplies that aren't consistent with normal standards of care. So what we need to do, and this is kind of what I've been helping with at Ohio State, is strategies for both preparing and then conserving, substituting, readapting, and then as a last case, scenario would be reallocating resources. So this was very commonly talked about in Italy. You have 100 ventilators. These patients, again, get sick. They need ventilators. You have 100 ventilators, but you have 500 patients. How do you allocate those scarce resources? So, what we do is we think about each of those things, and then we have a team that's going to help allocate those. So we're under a state of emergency right now, and the governor, I think, has done a great job of being proactive with social distancing, trying to keep that curve low. So just to talk about that for a second, the goal of social distancing is to stop the droplets from spreading from person to person. And if we're not together in a space, coughing on each other or breathing or touching each other, then those droplets will stop spreading. I said we have a finite amount of space in the hospital. We know that we have 92 negative airflow rooms. We're not going to have more of those. That's the number we have. So we have to think about, if we can slow down the number of patients that come to the hospital or to the emergency department, we can cycle through those 92 rooms much slower. If we fill all 92 in one day and they're filled with sick patients, then when the next 92 come the next day, we don't have those beds. So again, we're trying to slow our roll here with 10 or 15 patients being sick and hospitalized over a week instead of 100. And again, people don't want to hear this, but we want to stretch this out. Actually, we don't want to go through what Italy's going through in 1 month. We want to stretch this out over the course of 3 months, let's say, and into the summer, and see people in stages instead of all at once. So, again, as far as staff is concerned, we've had our medical students come out of the clinical environment. We're only using these scarce resources like the N95 for people that need to go in to intubate a patient, to do a test, to do a neb. We don't want 3 different learners going into the room and using up all of our stuff. As far as space, we may be closing regular clinics to use that space. I can tell you yesterday, we stopped our elective surgeries because when we do elective surgeries, patients get admitted to the hospital. Those patients use up a lot of the space. So those are the strategies. So right now we have different working groups at Ohio State. We have one that looks at space, one that looks at alternate care sites, one that looks at the supply chain, one that looks at the labor force and the healthcare force, one for testing and clinical care. And I would surmise that really every health system is kind of looking at this in the same way, trying to preserve these resources while still providing really high quality care to people. So I mentioned I'm an emergency physician, and I think for better or for worse, we have a philosophy of send them to the ER or go to the ER. They can fix, whatever that problem is. But the whole point of this drive-through testing or testing and screening people before they come into the ER is to preserve those resources for patients who really need them. The elderly, short of breath, can't breathe, needs oxygen, might need a ventilator. That patient absolutely needs to be sent to the ER. The 20-year-old just got off a cruise ship with some body aches and a mild fever. Yeah, they probably have COVID-19, but they don't need an emergency department. You could even argue that they probably don't even need a test. What they need is to go through the drive-through testing, get diagnosed, and then go home quarantine, stay away from everyone that you can come into contact with, and really try to keep yourself clean. As far as home quarantine, the goal here is to stay in your own part of the house if you can, wipe down all the surfaces, hand hygiene, wash your hands as much as you can. If you can use your own restroom, own bedroom, and you have those resources, that's really important. As I wrap up a little bit, pandemic preparedness is happening all the time. It's not just happening now. I mean, we've been preparing for this. We knew from our hazard vulnerability analysis that this could happen. Ohio does have a drafted plan for the allocation of scarce resources that would look at the ethics of who gets a ventilator, looking at exclusion criteria, like if you have severe burns, severe trauma, end-stage dementia, maybe you don't get a ventilator if you're compared against somebody who's young and otherwise healthy who needs one. And again, we're just continuing to work every day to think about the conservation of space, like hospital beds, staff, like emergency physicians, critical care physicians, nurses, and supplies, like these N95s, the swabbing tests, gloves, gowns, all those things that we need to do. So I appreciate you listening to my talk about COVID-19, how it presents, and pandemic preparedness. If you have questions, you can reach out to me on social media. I'm on Twitter at Dr. Nick Kman, DrNickKKMAN, and I'm sure my email hopefully will be linked to this. So thanks a lot. Stay safe, stay distanced, and keep the faith.